Hi everyone, thanks for watching. My name is Tracy. I'm a first year nursing student and today I'll be talking about Croup. Before I begin, I wanted to start off with a disclaimer. I'm going to read this little blurb, so bear with me. Please be advised I'm a student just like those of you watching. Making this PowerPoint is a way of helping me study, and I hope this resource can aid fellow nursing students in their studies. With that being said, I'm a first year nursing student and not an educator or a tutor. I do not represent the nursing program and institution that I attend in any way, shape, or form. Also be advised, I do not have complete knowledge of the topic. This presentation simply outlines my notes and understanding of the disease process. So, now that that's out the way, let's get into it. All right, so what got my patient here? What are my risk factors? So, Croup definition, acute swelling of the airway. Occurs in children 6 months to 3 years old. How does Croup happen? What's the risk factor? Long story short, an unresolved respiratory infection or a pre-existing pulmonary condition. So pretty much they had a cold, influenza, some type of something going on that didn't solve all the way and manifested in the Croup. So when we're dealing with Croup, what does my patient look like? What are the clinical manifestations? So to begin, we got to know that there's two types of Croup. Bear with me for this pronunciation. Acute laryngeal-tracheobronchitis. All right, so here's the symptoms that are associated with that type of Croup. So low-grade fever. Again, we have an infectious process going on. White blood cells are going and flowing and doing what they do. We're going to have a low-grade fever. Fever with that. So again, swelling of the airway. We're trying to breathe. The patient's going to present with signs and symptoms that they are having difficulty breathing. So dyspnea, cough, shortness of breath, use of accessory muscles, anything that they can do to maintain that airway clearance. So especially in our younger population, they're belly breathers, they're not chest breathers, so their use of accessory muscles is probably going to look like the nose is flaring, any way to get air in. Another important thing to consider is this type of Croup presents with stridor. So when they're coughing and breathing, it's just this awful noise going on. So that's a medical emergency. Second type, acute spasmodic laryngitis. That presents with a cough. Of course, if their airway is obstructed in some way, it's a response to cough in order to maintain that airway clearance. The patient's going to appear restless. I believe they're also going to appear restless with any type of Croup. Especially children, they're not breathing, something's off, they're not going to be comfortable, especially anybody would. If they can't breathe, they're not going to appear fine, they're going to appear restless in some way. Hoarseness, again related to that cough, and nighttime laryngeal obstruction. We went over what brought our patient to the hospital. We went over what they look like, what are their symptoms. So now what are we going to do about it? What are our interventions? So two goals come to mind when I think of Croup for interventions. The first is patient safety. So first things first, you never want to leave the child unattended, especially if they have an airway issue, and kids are kids. They can touch something, do something, we don't know. Either way, we want to be there in the event that they lose their airway, make sure they don't do nothing to lose their airway. We just don't want to leave the child unattended. Second thing, NPO. Don't want them swallowing anything. Again, we have an airway issue. There's some obstruction. We don't want to risk aspiration pneumonia, choking, none of the above. So nothing by mouth until the child can tolerate it. Emergency airway ready at the bedside. Again, since it's a swelling and inflammatory process, that airway could be lost at any time before we know it. So we definitely want to have some type of backup plan to keep that airway patency in the event that we need it. Again, maintain their airway. Some interventions to promote ventilation, you want to put the child in high flowers, elevate the bed, keep them upright. You don't want them laying on their back, compressing the lungs. That isn't going to help with their breathing. Administer oxygen as prescribed. Again, with any oxygenation issue, the second concern is perfusion. Is oxygen getting to all the tissues as needed? So if their pulse ox is low, SpO2 appears low, we're going to want to administer oxygen. IV fluids. So with the increased metabolic needs of the baby breathing excessively and all out of breath and using accessory muscles, that's going to take a toll on the body and that's going to dehydrate them. So you definitely want to provide IV fluids, also considering that the child can't have anything by mouth. So we want to keep the fluid electrolyte balance going and administer IV fluids. Administer corticosteroids. Since we have a swelling and inflammatory process, corticosteroids will work in reducing that airway. So we want to administer those as prescribed. So we come to the point. We've done our interventions. How we reassess? A respiratory assessment. Because we're given things like O2 therapy, corticosteroids, elevating the bed, we want to make sure that these are actually effective in maintaining that airway. So we're going to listen to our lung sounds. Nothing janky going on, no aspiration happening, none of that. Respiratory rate and quality. We want to know how fast they're breathing, but we also want to know the quality of those respirations. Are they using accessory muscles? Like, what do they look like? Is this improving with our interventions? That's what we want to look out for. Also, we want to look out for that pulse ox, make sure oxygen is getting to the tissues, perfusion is happening, all that good stuff. So, again, respiratory and cardiovascular go hand in hand. Again, that circulatory system. So you want to monitor the heart rate and rhythm, because chances are if the baby's not breathing, I'm going to call him the baby the whole time. 6 months to 3 years old, they the baby. So if the baby not breathing, heart rates compensating to get oxygen flowing. The rhythm might be off. So those are also things you want to monitor in your assessment and reassessment. Changes in mental status and continued restlessness. So if oxygen isn't getting to the brain, into the body as needed, there's going to be a change in mental status. The baby's still going to be continued restless. If that's still the case after we implement our interventions, how are we changing the care plan? What else needs to happen? Hydration status, also super important. Again, our littlest population, 6 months to 3 years. Surface area of the body, very small. They can dehydrate super fast due to that metabolic process, trying to compensate, trying to breathe. All that's happening, putting excessive workload on the body, leading to dehydration. What are we going to do? We're going to monitor that urinary output, make sure the kidneys are functioning. Again, they're also on an NPO. They're getting IV fluids. We want to make sure they're peeing it out, it's going in the right direction. And then monitor your fluid and electrolytes just to make sure there's no imbalances there. So, we're at the end. Baby's happy, yay, they're going home. Well, before even they go home, we're going to do this at the bedside. It's upon admission. What are we teaching our patient? In terms of patient education, we want to consider the parents, because again, we're not teaching a 3-year-old to keep up with their vaccinations. So first point, vaccinations. Think of the risk factor. The primary risk factor for Croup is an unresolved respiratory infection. So is our child up to date on the vaccinations? Are parents aware of vaccinations? What ones they need to get? What's the time for them? Do they have access to health care for the child? Like, all these things gonna play into vaccinations status. How to care for respiratory infections, especially with new parents. They may not know what's going on. So making sure they're aware of how to treat respiratory infections at home and at what point do they need to loop in the doctor. So, summarize it all up. Quick and dirty. So, this is in no particular order. I just wanted to make that very clear. No particular order. Just the stuff that I found most important to me in my studies of Croup. Your top 10 or top 9 or top 8 or top 5 may be your own. That's okay. But I'm going to share mine. First things first, primary risk factor, unresolved respiratory infection. Croup is a swelling of the airway. With that cough and that breathing, they're going to sound stridorous, which is a medical emergency. That airway is thin, lacking, and we need to help it. Again, in terms of safety, we never want to leave our child alone, and we don't want to give them nothing by mouth due to risk for aspiration until we know we can tolerate it. Monitor respiratory status for improvement. Again, our interventions are O2 therapy, corticosteroids, elevating the bed. We don't want to just do an intervention and not make sure that it's working. Elevate the head of bed. Again, I mentioned that earlier, just to promote that ventilation and keeping the emergency airway ready. All right, I hope that wasn't too fast. That is the end of Croup for me. I hope this is helpful for y'all. And yeah, thanks for watching. If you have any study tips for me, or if there's feel like there's anything I missed, please let me know so that I can improve upon these. Don't want to just keep these where they at. I definitely want to improve so that I'm helping everybody. Bye.